Hello, my name is Fadi Saab. I am the Chief Operating Officer at Advanced Cardiac and Vascular Centers for Amputation Prevention. It is a great pleasure for me today to be participating in NCVH virtual. The topic of discussion today is pedal artery access, when to use, and how to avoid problems. I would like to take this opportunity to thank the course directors, especially Dr. Walker, for including me on this important meeting. So starting with pedal access, it's important to dive into one of the important topics that's been gaining momentum lately within the last few years. The tibial arterial minimally invasive retrograde revascularization, or the Tammy technique, it's a procedure that we have started performing almost for the last 8 or 9 years. And it depends on utilization of pedal access not only to cross the lesions, but also to deliver therapy. And you perform pedal access using ultrasound guidance. You perform diagnostic angiography via pedal access. You utilize extravascular ultrasound. You can also utilize intravascular ultrasound. You can perform atherectomy, balloon angioplasty, drug-coated balloon angioplasty, and even deploy self-expanding stents if necessary or if needed for those cases. So one of the things I like to always portray is kind of give a three-dimensional image for our physicians, our audience. So the idea is always to go via pedal access, no groin access, as you can see in the right panel. So either utilizing the dorsalis venous artery, anterior tibial artery, the posterior tibial artery, or even the peroneal artery if needed. And as you can see here, the direction of therapy is from the pedal axis up. But you see the arrow in the middle, and in the example that I'm going to share with you during this presentation, you can actually treat from one of the tibial vessels to the next tibial vessel, so from the anterior tibial artery to the posterior tibial artery, or vice versa, or even the peroneal artery, as long as the angle is favorable, and we'll discuss a little bit more about this topic. Why would you like to use the Tammy technique? Well, the risk of complications is high via groin access for a lot of the patients. Could be because of obesity, could be a hostile groin, could be a surgical site, it could be an infection of the site. I mean, the list goes on and on and on. And in many of those cases, groin access will increase the risk of complications. Closure is not feasible for the access. Patients that had possibly aortic bifam bypasses, you cannot go up and over, or you cannot even obtain antegrade access. Surgical sites, morbid obesity, as I mentioned before, all of those factors can be prohibitive from obtaining traditional common femoral artery access via antegrade or retrograde access. So again, these are some of the pictures for one of our live models that I like to show in almost in a three-dimensional fashion the path of these tibial vessels. So for example, here you can see the anterior tibial artery going into the intraosseous membrane through the anterior compartment, traveling under the anterior shin all the way to the dorsalis venous artery, providing the medial and lateral malleolar branches, and ultimately into the arcuate artery in the superior digital branches. Or you can see the TPT trunk traditionally into the peroneal artery, providing the anterior and the posterior communicating artery, and finally the posterior tibial artery, which ultimately travels within the posterior compartment. And you can see that the posterior tibial artery supplies the plantar aspect of the foot through the medial and lateral plantar artery. And again, I'm trying to show this overlay. These are actual arteries that we mapped with this model because I wanted to for the physicians to conceptualize how do these arteries travel, because we tend to show the angiography pictures and we tend to show the three-dimensional structure in a two-dimensional way. So I want to introduce this new concept of assisted Tammy. So it's the same thing. It's pedal-based revascularization, ultrasound-guided access of the pedal vessels, but also ultrasound-guided access of the common femoral artery or the superficial femoral artery in an antegrade fashion. Now, you may ask, well, how is that different from a traditional antegrade retrograde access? Well, the biggest difference here is we are utilizing a micropuncture 2.9 French or 3 French sheath to obtain access within the superficial femoral artery or the common femoral artery. And one might ask, why would you do that in this assisted Tammy concept? because the nature of the chronic total occlusion, albeit in the SFA or in the popliteal or in one of the tibials, might require dual antegrade and retrograde access. But to put a larger sheet to deliver therapy, 5 French or 4 French or 6 French or 7 French might be challenging and increase the risk of complications. So the physician might still choose to deliver therapy via pedal approach and via the Tammy technique. And to elaborate on this subject a little bit more, the CTOP trial was the first trial to discuss the types of CTO within the peripheral circulation. This work has been started in 2018 by our group and was built on by other groups to validate the model in other peripheral studies. And essentially, you have 4 types: type 1, type 2, type 3, and type 4. And based on the concave or convex nature of a proximal and the distal CTO cap, you might require antegrade or retrograde access to cross the CTO and ultimately deliver therapy. So again, with assisted Tammy, low profile 2 to 3 French antegrade access, but pedal-based revascularization for a lot of those patients. Why assisted Tammy? Well, again, there are some limitations for groin access. You know, you might be comfortable placing a micropuncture sheath in there. The risk of complications remains low. Hemostasis may be achieved via pedal access. What I mean by that is after the physicians have crossed the CTO, delivered therapy, they can balloon tamponade the SFA or the common femoral artery access via pedal access, and it's an EVIS guided closure, meaning extravascular ultrasound guided closure, and there's no complications. If you look at the CTOP trial, the predictors of crossing direction were very simple. You know, it was a logical trial. It really fits with what a lot of us physicians do nowadays. If it's a type 1 CTO, the likelihood of crossing in integrated fashion is very high. If it's a type 4 CTO, the likelihood of crossing a CTO in a retrograde fashion is extremely high. If you look at the predictors of requiring pedal access for a CTO, these are the major predictors: type 2 and 3 CTOs, lesion length greater than 10 centimeters, severe calcifications. All of these, if these factors are noticed within a patient or within an anatomical CTO, the likelihood of requiring pedal access is extremely high. The highest predictors, the highest predictor, believe it or not, was severe calcification. If you note severe calcification on ultrasound imaging or fluoroscopy, the likelihood of requiring pedal access ranges anywhere from 8 to 10 times more compared to traditional access. Now let's dissect this concept of why is it important to have this assisted TAMI concept or this pedal access based revascularization. Because for our non-surgical colleagues, this is an example of the common femoral artery and the femoral head. And you can see that there's a compressible zone where the common femoral artery is, and there's a non-compressible zone, which is beyond the inferior border of the common femoral head. We tend to evaluate the compressibility of the SFA under ultrasound, and the first 1 to 2 centimeters tend to be compressible against the common femoral head. So let's show an example of a TAMI or an assisted TAMI technique. This is a 79-year-old with history of retroperitoneal bleed and a covered stent in the common femoral artery. Breathalyzer class 5, occluded AT and DP and PT with diffuse SFA and popliteal disease. Really no groin options, and regular tibial access is not feasible. So I've shown these slides before, and I continue to show them because a lot of physicians still ask the question, can you access occluded tibial vessels? And the answer is yes, but not all occluded tibial vessels are created equal. So this is a comparison on the left-hand side and the right-hand side between possible access, vessels that you can access, and the right-hand sides are vessels that you cannot access. Let's look at the vessels that you cannot access. Well, there's no clear layers, as you can see here. When you're evaluating the tibial vessels, there's a lot of acoustic shadowing, severe calcification, and the vessel is non-compressible. Versus the left-hand side, this is an occluded tibial vessel, but you can clearly see layers of the vessel, adventitia, media, and intima. There's a hypoechogenic lumen occluded, but it's hypoechogenic, and it's a compressible lumen, so the physician can use ultrasound to access it. And this is an example. On the right-hand side, you see what happens to the wire being advanced in the occluded tibial vessel. On the left-hand side, you see the ultrasound-guided access of the tibial vessel. As you can see in the top left corner there, the wire is being advanced into the occluded tibial vessel, as you can see in this example provided. And ultimately, once you deliver therapy, or once you cross the CTO, you can ultimately deliver therapy. In this example here for this patient, you can actually access the anterior tibial artery in an integrate fashion. So going back to our patient, this is our patient. He has an occluded anterior tibial artery. He has an occluded dorsalis venous artery. He has an occluded posterior tibial artery also, right? So, and these are occluded tibial vessels. You cannot access these vessels via the groin axis because of the limitations and the groin complication and the fact that there's a covered stent in the common femoral artery. And doing tibial work or plantar work in an up and over fashion is extremely challenging. So what we did is we accessed the distal anterior tibial artery in an integrate fashion, and we crossed to the dorsalis venous artery. In the angiogram, as you can see here, you can see the digital branches lighting up the superior digital branches. And then we move on through the pedal loop to cross to the posterior tibial artery using a support or 018 support to Rumo Navicross catheter and an 014 command wire. And we were able to basically cross to the distal posterior tibial artery. And in this particular example here, I chose to deliver laser atherectomy followed by balloon angioplasty. So let's see what happens next. So after we performed atherectomy of the posterior tibial artery, we proceeded with performing balloon angioplasty, as you can see here. And you can actually see some competitive flow because there is some flow through the perineal artery, but we clearly treated the dorsalis venous artery here. There is some recoil at the dorsalis venous artery area here, but we were able to treat the pedal loop. Now remember, we still need to treat the SFA, the popliteal, and the proximal tibials are still occluded. So what do we do here? So let me walk you through this again. So we chose to, after we treated the dorsalis venous artery, we accessed the dorsalis venous artery and advanced an 018 wire. As you can see this example, in this example here, the 018 wire was advanced into the antegrade anterior tibial artery sheath. Now, once we secured our wire for the dorsalis venous artery, we decided to pull our sheath from the anterior tibial artery and advance our wire into the anterior tibial artery proper in a retrograde fashion. So we treated the dorsalis venous artery, it's open now, and now we're crossing with our wire to the occluded anterior tibial artery. So let's see what we did next. Now I want to show you the anterior tibial artery access site. This is actually the anterior tibial artery access site. You can see here that we inflated a balloon within that segment. The other thing that we can do is basically apply our ultrasound. We call EVIS guided closure. Apply our ultrasound to apply manual pressure and see that there is no bleeding coming out of a site. And this is after manual pressure was applied. You can also perform balloon angioplasty to tamponade the access site from below. But nonetheless, we were able to make sure that there is no bleeding that's coming out from the access site within the anterior tibial artery. So let's try to slow this down a little bit. And I apologize, I actually rotated the ultrasound images in a way that kind of superimpose what's going on in fluoroscopy. So in this example here on the right, basically you see us pulling the sheath and we inflate the balloon as we pull the sheath. So this is the sheath being pulled, as you can see in the example here. And as the sheath is being pulled, we inflate a balloon. So this way there is no bleeding from the access site, as you can see here. In this example here, you can see us advancing the wire. This is the wire being advanced under ultrasound into the tibial vessel proper while we're delivering therapy. So what we chose to do is access cross the anterior tibial artery to the popliteal artery. This is the intravascular ultrasound Phillips probe. We were able to perform IVUS evaluation from the anterior tibial artery into the peroneal artery. So this is what we call transtibial intervention. This is laser atherectomy using a 1.4 laser device being advanced over an 014 command wire. And I want to show you how the command wire is behaving as it crossed also into the popliteal artery. So the point is, you were able to go down to the peroneal artery, you were able to go down to the posterior tibial artery, you were able to go up to the popliteal artery. So your options are not limited as what a lot of people think when you're treating those patients. So I want to show you the final result. We treated the SFA and the popliteal. It was non-occlusive, I want to show you the final result. This patient, we were able to treat the anterior tibial artery, we were able to treat the peroneal artery, and we chose not to pursue the posterior tibial artery because it was filling via collaterals. And as you can see here, complete pedal loop through the lateral plantar artery into the dorsalis venous artery after we performed the angiogram. So we treated the SFA, the popliteal, the anterior tibial artery, the TPT into the peroneal artery, and the distal posterior tibial artery, all via the anterior tibial artery axis and the dorsalis venous artery axis. We published this year in the CCI journal our findings from the prime registry for the Tammy patients. We included about 101 Tammy procedures, compared it to dual axis antegrade and retrograde and traditional femoral axis. And we looked at some of the variables within the trial. Lesion location, where is the location? Was this a stage intervention? You will notice that the Tammy technique tends to be more of a stage intervention. About 30 to 35% of those patients were target vessel, target lesion revascularization, and these lesions were not short. 200 millimeters, the average lesion length, in comparison to 330 millimeters for the dual axis antegrade and retrograde. And most importantly, the complications rate related to pedal axis was extremely low. So when it's performed in sites that are proficient in performing pedal axis, the rate of complication is extremely low. So when to use tibial axis to treat tibial CTOs? Obviously, we still tell physicians, do not obtain pedal access if the patient is asymptomatic or they have a single vessel runoff and they're claudication patients. I'm a huge advocate for using sheaths, especially to deliver therapy, not necessarily just crossing the CTO. If you have a short CTO or type 1 CTO, you don't necessarily need utilize pedal access. But when would you use pedal access? Well, CLI patients, type 2 and 3, long CTOs, heavily calcified vessels, reconstitutions of CTOs within the tibial vessels, you must consider tibial axis. In fact, you must start with tibial axis with some of those cases. What happens when you ignore these rules? So this is actually one of my complications. This is a young patient presented with rest pain and wound in the right great toe. She underwent a right column femoral artery endarterectomy with poor outflow and continues to complain of rest pain. Needless to say, the patient, we were unable to obtain groin access. It's a smoker patient with small tibial vessel disease and some embolization to the plantar and distal tibial vessels. Obtaining antegrade access was not feasible, and you can see why. So we had to go up and over a contralateral groin, and the patient is somewhat tall, so we were unable to just to cross the CTO in upper over fashion. So we had to access the occluded anterior tibial artery, as you can see here in this example, and cross the pedal loop. We were able to deliver therapy. But what happened is, did not use a sheath, and the patient ended up developing a pseudoaneurysm at the axis location, as you can see here. That was recognized immediately, and we're able to control this issue by applying manual pressure. just an example that we did not use pedal access. This is another example. This is one of the earlier cases where we delivered therapy via pedal access, but we did not use a sheath. This is a very old complication where we did not even we tried to place a stent in a sheathless fashion, and unfortunately ended up injuring the vessel quite severely, as shown in the example here. And we had to place a covered stent at that location. The patient did okay. And this is actually before the days of using precision sheaths or slender sheaths for those patients. I think this is the only complication that I can remember in my practice, at least, that I had to place a covered stent, and I think it was related to sheathless access in that situation. So, in conclusion, pedal access has been shown to be safe and effective. Offers significant advantages in crossing CTOs and delivering therapy. Proper clinical and anatomical assessment is required before deciding the need for pedal access, and more physicians need to adapt a pedal first approach in complex CTO cases and peripheral cases. And complications are extremely rare and can be managed whenever they happen. Thank you for listening to this presentation.